Hello, I'm Robert Pilot of Native Roots Radio presents I'm Awake. And Native Roots Radio hosts a native centric radio program every weeknight on AM 950 and other stations throughout the Midwest. This month is Cervical Cancer Awareness Month, and we're glad to be working together with the Minnesota Sage Cancer Screening Programs to present this event, reducing the impact of cervical cancer in Native women. The Minnesota Sage Cancer Screening Program partnered with Native Roots Radio to get this important message out of reducing cervical cancer in Native American women. Native Roots Radio will be on social media, Facebook, Twitter, YouTube, and also on bit.ly/AI Sage Cancer Screening. This event will also air next week in the Twin Cities on Sunday at 6 p.m., January 30th. On Native Roots Radio, we always welcome Dr. Stately, the CEO of Native American Community Clinic, every Monday. And we have a guest from NACC on the show tonight wanting to highlight these connections with our Native communities. I would like to introduce our host, Dr. Melanie Peterson Hickley, an Ojibwe from the Lac du Flambeau tribe in northern Wisconsin. Melanie has 20 years of managing public health programs and has been an advocate and a champion for health equity movement with MDH. And I really am pleased to introduce you, Dr. Melanie. Thank you for being on.
Thank you, Robert. Really appreciate the introduction and really appreciate the invitation for us to be here this evening. Really excited to introduce our panel members. First, just another little introduction of myself. As Robert mentioned, I'm Ojibwe from the Lac du Flambeau Reservation in northern Wisconsin. I've been employed with the state of Minnesota for about 30 years. About 20 of those have been with the State Department of Health, Minnesota Department of Health. And I just wanted to differentiate because this is always kind of something that brings a lot of confusion. I work for the Minnesota Department of Health, and Minnesota Department of Health is a public health state agency. We deal with population health as a whole. So you can imagine in these past 2 years or so since the pandemic, we've been really focusing on COVID and getting the word out about vaccinations and masking and all of those measures. DHS is another of the state agencies. It's actually the largest state agency in Minnesota, and they focus on ensuring that everybody has their basic needs met. So they focus on things like healthcare coverage, economic support, food support, child protection, chemical dependency, disabilities. So MDH, again, is the public health agency in the state. I've been employed, as Robert mentioned, for a lot of years with the state of Minnesota. My greatest interest has been health equity because I really like the concept of creating the environment for people to be healthy or for people to have whatever it is that they need to be healthy in their communities. Those things include building strong communities, supporting strong communities, supporting the development of the next generation of public health leaders, and also just about, creating that environment, laying the foundation for people to access what it is that they need to be healthy. I'm really excited to introduce our panel members tonight. We're going to start with Tina Nelson. Tina Nelson is a team member of mine, and I'm going to hand it over to Tina to introduce herself and tell us a little bit about where she works.
I work with Melanie very closely. I co-direct the Minnesota Department of Health SAGE Breast and Cervical Cancer Screening Program with Melanie. She is the co-director as well. And I also direct the patient recruitment and evaluation for SAGE programs. I have been with the Department of Health for about 24 years, and about 19 of those years I've been with SAGE programs. I have my Master's of Public Health from the University of Minnesota in Environmental and Occupational Epidemiology, and I am very passionate about working towards decreasing health disparities and inequities in Minnesota, which is why I've stayed in my job for so long. It's really important to me to ensure that we are all working together in our state to try and decrease those disparities. So, thanks, Melanie.
Thanks, Tina. So we'll hear a little bit more about SAGE later on. Can you start out by just giving us a definition about what cervical cancer is, and maybe about how many people are affected by it in the state and in the U.S.?
Okay. Cervical cancer, it's a disease where abnormal cells, they'll grow out of control in the cell lining of the cervix. It impacts about 13,000 people per year in the United States and about 140 people per year in Minnesota. It occurs most often in people who are older than the age of 30. And there are definitely disparities in regards to cervical cancer, which you'll hear about a little later. Also, I want to mention that more than about 4,000 people in the US die every year. In Minnesota, about 35 people die from cervical cancer.
Tina, I'm going to switch up the question a little bit. Does cervical cancer impact Native communities differently? And if so, could you tell us how?
Yes, actually, that's a very good question. And it does. And it kind of touches on what I mentioned before, the disparities, that there are definite disparities, unfortunately. Cervical cancer has been shown to disproportionately affect Native communities. And what we see is American Indian women in the United States and in Minnesota both are twice as likely to develop cervical cancer compared to non-Hispanic white women. Also, American Indians have much higher rates of death from cervical cancer than the whites as well. One more thing to add to this, which is really important, is that the American Indian women also are diagnosed often at later stages. And when they're diagnosed at later stages, it makes it much harder to treat or to cure, which in this case it can be cured, but it is much more difficult if it's found at a later stage.
So, Tina, can you tell us, are there things that one can do to prevent cervical cancer?
I can, yes. There are ways to prevent cervical cancer, which I know may sound difficult, which they are, but it's the same time, there are things that we can do on a regular basis to help us, and that is pap smears. They're tests that actually look for the cell changes in the cervix. I mentioned what cervical cancer is and how it's abnormal cell changes that grow out of control. Pap smears can actually identify this when it occurs. So that's identifying cervical cancer. And if you get them regularly, they can actually find those cell changes early before cancer's had a time to develop, which is really important. Furthermore, to prevent cervical cancer, to catch it early, what we do in SAGE and others, other medical professionals, are often advise individuals over the age of 21 to get their pap tests regularly. And we encourage people ages 9 to 26-year-old to also get their HPV vaccines. And you may have heard about HPV, human papillomavirus. It's a virus that causes it's almost actually 100% of cervical cancer, and I think they say it's about 99.9%. And it's a virus that's transmitted from person to person through sex. The HPV vaccine, which I mentioned, is advised for individuals 9 to 26 years of age, will protect you. It actually prevents over about 90% of the HPV related cancers. And it's especially important in this case, in our conversation today, to note that American Indian women actually have the highest rates of HPV-associated cancers. So what I would do is strongly encourage women out there to take care of their health by getting that Pap test on a regular basis, and to also talk to their doctors about HPV vaccines. Even if you're not within that age category of 9 to 26 years of age, still talk to your doctor about that HPV vaccine. It's important.
Thanks, Tina. Some important reminders. So could we go back and could you tell us a little bit about SAGE and how it can help connect people to cervical cancer screening?
I certainly can. SAGE has been around for a very long time. We just had our 30-year anniversary this year, and so we've had a lot of experience in helping women connect to services, both breast and cervical cancer services. And what we do is we try and target priority communities who are needing our services most. We focus on individuals. Actually, our program provides coverage for individuals who are within 250% of the federal poverty line in regards to income. They're and underinsured, and they're between the ages of 21 and 64 years of age for cervical cancer and 40 and older for breast cancer. So those are our eligibility criteria. We provide we cover the costs for Pap tests and for mammograms for individuals. And if an individual has an abnormal screening, we also connect those people to some diagnostic services, and we'll pay for those diagnostic services through our program. And if they're unfortunate enough to have a diagnosis of cancer, we connect them with something that's called Medicaid for breast cancer, which is through, as Melanie mentioned earlier, the Department of Human Services. It's something that will cover your treatment services, which is really beneficial for people going through this if they don't have insurance to cover it, because it can get very expensive. We work our program, just to give you more information about the program, we work with about 455 clinics in the state. It's all throughout the state. We're actually in 86 of 87 counties. And so pretty much every person out there should have at least fairly convenient access to one of our clinics. And so we have a call center too. So our call center, I was going to mention the number later, but I'll mention it right now. It's a toll-free number, and so it costs you nothing to call. We have patient navigators standing by who can actually answer your questions and connect you with services and can schedule your appointment for you. And they work only day hours, but if you leave a message in the evening, then they'll call you back within 24 hours. They actually work as navigators for us, and they help you understand where the clinics are. They guide you to get the scheduled appointment, and then they help answer any questions you may have about that cervical or breast cancer screening. Other than that, I guess I can also mention some of the other things that we do as a program. We work with partners all throughout the states. And for example, we work with the Office of American Indian Health. We work with the American Indian Cancer Foundation. We have 2 urban Indian clinics. It's the NAC and IHB, which I know Robert just mentioned NAC because Dr. Stately's from NAC, and we also have one of our other panelists here today from NAC. And then we also work with 10 tribal reservation clinics in the state as well. So we have a broad network of partnerships. That's just primarily our American Indian partnerships, but we have so many more partners that we work with. We work closely with the comprehensive cancer section in the state that actually builds the cancer plan for our entire state. And they work with the Minnesota Cancer Alliance, which represents all the stakeholders in the state who really focus on cancer. So we do a lot from our program. We also work with all of our 455 clinics to try and improve their health systems flow within their clinics and try and help them work to improve their systems and try and find people in their area, in their geographic areas, who are eligible for our program or may not even be eligible for SAGE, but may be age appropriate for screening and need to get in for screening. So we help them, we guide them, and provide technical assistance for them. One other thing that I just want to mention is one of the most important things that I think our program does is we touch the lives of so many people. The people who've been screened through our program, the people who we talk to, who we navigate, family members of people who we connect with. there are a lot of real stories out there, stories of women who have said to us before that we've saved their lives, or they feel that we've saved their lives. And I think that those are the most important things about our program is we really connect with the people who are screened through our program. We do our best to help them get screened again when they're due for cancer screening. And I do think it's just, for me, it's a very rewarding position to be in. And I hope that we can connect with more people out there. That's our goal. Is Melanie, I, and others within SAGE and our partners have really talked about working with our community even more so than we have in the past, and trying to be guided by the communities, because you know the people who are in your community best, and you can help us identify who needs our services. So that's, I guess, more about SAGE, Melanie.
Thanks,
I could
Tina.
probably go on and on, but I'll let you go.
That's great. Just as a note, one of the things that you said is that we have 455 clinics across the state,
Right.
but there are many other clinics across the state that might not be SAGE providers, that people can get their preventative services, their screening services from. SAGE is a program that helps women that can't afford it, don't have the resources, or just need some help in sort of navigating our system. So the important part is, get screened, talk to your provider, get in there and get the services that it is that you need.
Absolutely, that is it.
So we're going to move on to the next speaker. Thanks so much, Tina,
Yeah,
for
thank
that
you.
information. It's really helpful to set the foundation for us. We appreciate it.
Thanks, Melanie. Thanks, Robert.
Hey, I just want to remember everybody what you're listening to. You're listening to, this month is Cervical Cancer Awareness Month, and we're glad to be working together with the Minnesota SAGE Cancer Screening Program to present this event, Reducing the Impact of Cervical Cancer in Native Women.
So we're going to move on to our second panelist this evening, Mariah Johnson. Mariah has been at the Native American Community Clinic and working with the SAGE program as our SAGE champion for the past 7 years. She is a dietitian by trade, and she oversees the community health department at NAC as the community health manager. Her colleague, Dr. Stately, is a frequent guest on Native Roots Radio. Just as an aside, welcome, Mariah. Do you want to go ahead and introduce yourself and give us a little information about NAC, Native American Community Clinic? You might be on mute, Mariah.
Thank you.
There you go.
So the only things I would add in addition to that is that NAC as a clinic has been working with the SAGE program since the beginning. The clinic doors opened in 2003. So we have been a really long-standing partner of the SAGE program. The clinic founders definitely recognize the need straight away, right out the gate, in making sure that we were a SAGE provider. So the other thing I would add just about the clinic as a whole, so we are a primary care clinic located just right in South Minneapolis, in close proximity to one of the other urban clinics serving the Native population, Indian Health Board. And so with our primary care focus, we of course are really emphasizing the importance of getting screened for cervical cancer, but not only that, but also breast and colorectal. Just as I had mentioned, being a primary care clinic, it is a really critical thing to make sure that we are helping our patients stay on top of.
Thanks, Mariah. So at NAC, I'm sure that you serve a lot of women, provide cervical cancer screening for a lot of women. Could you share with us who should be screened for cervical cancer?
Yeah, so as Tina had mentioned, we do recommend that women starting at the age of 21, they get screened starting then. But in addition to that, I feel like a question that we get asked a lot, and we come across it with some of our patients at the clinic, is if whether or not they should still get PAPs if they've had certain procedures like a hysterectomy and things like that. But I think it is important to highlight that anybody who has a cervix should still get screened for cervical cancer. So that means whether you are two-spirited, if you identify as a male or a female, you still have a cervix, you should still get screened. There's also the question of, like I'd mentioned, when women had maybe a partial hysterectomy and they still have a cervix, should still get screened as well.
Thanks, Mariah. You did mention national guidelines. Are there more than one set of guidelines? Can you tell us a little bit about what those guidelines are and what it might mean for us?
Yeah, so as a clinic, we practice using those standard guidelines. There are two large organizations that we look to in those guidelines that helps us guide the care that we give. The two reputable sources that we use are the American Congress of Obstetricians and Gynecologists and the United States Preventative Service Task Force. Both of those are ways in which that we educate the community and sort of guide the care that we're giving for cervical cancer screening. Like Tina had mentioned, and I had touched on a little bit before, we do recommend starting once again screening at the age of 21, getting that PAP every 3 years. Starting at the age of 30, then we recommend doing it every 5 years with the HPV co-test. In most cases, I know people, they ask about the HPV co-test. Well, I had a PAP and I'm, let's say, like 35 years old or something like that. Did I get an HPV test? I can say for at NAC, our clinic, we do what is called co-testing. So if you are above the age 30 and you get a PAP at our clinic, we do the HPV test as well. And so then you're good for 5 years. So that I find makes it easier, not having to do it quite as frequently with that co-testing. And it does sound complex. I understand that in some cases doing things yearly, that makes it a little bit easier to remember if it's just every single year. Whereas with these recommendations, they do change throughout the lifespan. So I think it is important to have that open dialogue with your healthcare provider and going in regularly, where we can have the opportunity to educate and help patients remember if they are coming due for that cervical cancer screen, because it is harder to remember when maybe it's not every year.
One of the important things that you mentioned, Mariah, is that there are these guidelines available. Where do women get the information about the guidelines? Is that in the conversation with their providers, or are there other resources for them to access information about guidelines, and what specific kinds of recommendations there is for them individually to get screened, and how often?
Yeah, so as I had mentioned, I always encourage people to have a good relationship, at least even backing it up, having an established primary care facility. Sometimes that's the biggest barrier, especially for that younger age group, that 21 to 29. I feel like that is absolutely a barrier. You're young, you're healthy, you don't really think about going to the doctor. And so we do worry about those, really the younger people, maybe they're not going in as regularly. So that is potentially a missed opportunity to have that open dialogue with their provider and receive the education on how often they should be getting screened. We do encourage people to take their care in their hands, do their own research. The only thing I would say is if people are looking up on online websites and things like that, as far as screening criteria, is to pay attention to reputable sources. Oftentimes I feel in community health, we're educating patients, look for the stuff that's .gov, .edu, and things like that when you are looking for health-related information, just to ensure that it is from reputable sources. Otherwise, like I said, that important relationship with your primary care provider, it's part of our job is to help people remember and educate and get that patient buy-in with some motivating factors to make sure they come in and get screened.
Thanks, Mariah. So NAC is located in the urban community here in Minneapolis. And one of the things that you do is you help navigate American Indians that live in the urban area through our oftentimes complicated health system. Can you talk about some of the barriers that you see women face as patients at NAC? What do you do at NAC to get women in for screening? What kinds of approaches do you use? What kind of outreach do you do with women?
Yeah, so we do a combination of trying to catch people while they're in clinic for another service. We always try to think of it as optimizing their time while they're on site, because we do know, the fast-paced life within the urban environment, the competing priorities that a lot of our patients face with other health conditions or social issues for not just themselves but their family as well. So when they're in the clinic, we do want to maximize their time, and that means reviewing their chart when they come in, if possible, having that conversation with them about them being due, finding out ways to most seamlessly flag the care team and the patient to alert them for a due or a coming due PAP. That's one of our really big ways that we're trying to get people up to date on screening. The other thing that we do a little less frequently, but we do some mass mailings for ladies that are coming due to get them alerted, and maybe a nice little warm reminder for them that way. The other challenge I would say, which it's sort of a misconception, is the access to resources within the urban environment. It's true to a degree, of course, but it's not the same access to resources and potentially streamlined care that some of the other patients that are maybe living on tribal communities see. I just think about some of our patients and having some of those conversations, and they may have gone to Fairview, or they may have gone to HCMC or Abbott, and they are unsure if they had a PAP there because they sort of are bouncing around from, place to place. And you ask them and they're like, I feel like I got it done at such and such place then. But you have this compartmentalized healthcare system that doesn't communicate well with one another. And, it seems so silly when everybody's in everybody's backyard, but we don't have access to that information to know whether or not this patient truly did get screened, or if they are in fact due. And so that's always a huge challenge. I would say that's unique within the urban environment versus some of those folks that are living on some of the tribal communities. It's all typically one streamlined system. It's not quite as many players in the game of providing healthcare. So that is another sort of unique challenge, I would say, that I feel anecdotally I see quite a bit. And when I talk to patients and hearing other staff and how they are interacting with patients and the responses they get.
Thanks, Mariah. I could easily see that happening in the urban area because there are so many different resources available, and then kind of not available in terms of just giving people access to the care it is that they need. So abnormal tests, sometimes the test will come back abnormal and women will need to do some follow-up. Could you tell us what NAC does, what they have in place to help women that receive abnormal results? And then what is the woman's role in that? What is NAC staff role in that? And then do you also work in getting women enrolled in MABC, as Tina was talking about earlier and as you mentioned?
Yeah, certainly. So regardless if a woman is enrolled in the SAGE program or not, it generally starts with the screening PAP. That's the one nice thing about the cervical cancer screen is we can provide it, of course, as a primary care clinic. So we get those results back quickly. We know we're able to contact the patient and let them know what the results are. If they're abnormal, of course, then the next step is having that conversation with the patient as far as what is going to happen next. As it's going to be a referral to typically a specialty care center for certain things like a colposcopy or perhaps a pelvic ultrasound, something like that. And so then we act as the primary care clinic in placing that referral and getting them linked up to wherever their choice of specialty care site is to get those, sometimes we call it follow-up or diagnostic procedures done. This is handled, like I said, by a care team that they know really well. They feel really comfortable. These are people they see hopefully quite frequently. And so I think that is an advantage that we have as a community clinic, is those strong patient connections to help them walk through those next steps for their diagnostic or follow-up procedure. If the woman needs help, or I should say the individual needs help getting those appointments scheduled, we can certainly help with that. And then we can also assist with getting them linked up with a medical ride through their insurance. If they don't have insurance, and this is an individual that is enrolled in the SAGE program, I know the SAGE program is really great. They provide transportation as well. So that's the option if they don't have insurance, or for whatever reason their medical insurance can't offer rides. That's one of the other nice things about the SAGE program, is it does help capture some of that underinsured population. And then after that, if a woman does go through, and I know Tina had touched on it a little bit before, if they do receive that cancer diagnosis, then we're looking at enrolling them in that MABC, so the Medical Assistance Breast and Cervical program. That is absolutely something that we help out with as a clinic. I've seen it, I've helped with it before. Once again, you're then interfacing with people that you're familiar with. So I do feel like, once again, that's an advantage of being a community clinic, is that we do have that standing relationship. So when it comes to really combing through that eligibility criteria in the event of a cancer diagnosis, and putting those pieces together for the MABC program, we're happy and in the right place to help out with that. So hopefully that helps walk through some of those steps of what happens.
Yeah, I think that it was a great description of what kinds of services are available at NAC. Certainly important in times where it must be really difficult for people to receive either an abnormal result or a cancer diagnosis. So just seems like NAC is a real critical community partner for women in the urban area. So NAC works with both breast and cervical cancer screening. Could you tell us about how and you've already talked about it a little bit, but how do you work with SAGE to help women that you see at NAC?
The way in which we help with SAGE is right from the beginning at the screening process. If a woman or an individual calls to schedule a PAP and they're seen for a PAP, we find that they're uninsured. We are filling out the SAGE paperwork with them, and then getting that sent over to the Department of Health, depending on, of course, what that result comes back as. Then the next steps will be taken as far as potentially the MABC. I know I'd mentioned that previously in the earlier comment. And same even with the mammography. Even though we don't provide mammograms on site, we do have a good relationship with Park Nicollet and their mobile mammography service. We do have them on site roughly about quarterly for a mobile screening event. And so in those cases, we are able to fill out the SAGE paperwork right there with the patient. at the time of screening, which is really an ideal situation. It doesn't always happen that way. And in those cases, we may find out that for whatever reason they were underinsured, or their insurance became inactive, or something else may have happened where it just was missed, the fact that they didn't have insurance and they got screened. And so we do reach out to the patient then after the screening and make sure that that paperwork gets done and gets sent off, so that way the patient is not being stuck with a bill. And then in the event of needing any sort of follow-up or diagnostic procedure, they've got that coverage ready to go.
Thanks, Mariah. I think you've described this partnership that's developed over many, many years. And, it doesn't really matter, who provides that navigation, who provides that follow-up, as long as we're all working together to make sure that women get services that it is that they need. Mm-hmm. I thank you, Mariah, for your comments. Really appreciate it. I think I'm putting this back to Robert Pilot of Native Roots Radio Production.
Hey, thank you. I just want to remind everybody what you're listening to. You're listening to this month is Cervical Cancer Awareness Month, and we're glad to be working together with the Minnesota Sage Cancer Screening Program to present this event, Reducing the Impact of Cervical Cancer in Native Women. So we really are proud to partner with you guys, and you're doing a great job, Melanie, and there's so much great information happening. I can't wait for the next guest to pop in.
Thanks, Robert. And we have a third panelist, last but not least, Melissa Buffalo. Melissa, can you go ahead and introduce yourself and tell us about ACAF and the work it is that you do at ACAF?
Yeah, Hanhempi Washte, Melissa Buffalo, Imachiapie, Michinchanum, UK. Good evening, and thank you for having me today. My name is Melissa Buffalo. I am the Chief Executive Officer with the American Indian Cancer Foundation. I am an enrolled member of the Meskwaki Nation in Iowa. I'm also Dakota from the Crow Creek and Lower Brill Sioux tribes in South Dakota. And most importantly, I'm a mother of two. Been with ACAF for almost 3 years, which is super exciting. We are a national organization, about just a little over 10 years old, whose mission is to eliminate the cancer burdens of Indigenous people through improved access to prevention, early detection, treatment, and survivor support. We truly believe that Native communities have the wisdom to find the solution to cancer inequities, but are often seeking the organizational capacity, expert input, and resources to do so. We really support innovative community-based interventions that, engage our Native communities in the discovery of their own cancer best practices. So really, meeting them where they're at and seeing what their readiness is to implement a program or to address the cancer burdens. And, we really, every project or program that we bring to ACAF, we do our best in partnership, and we strive to be that trusted partner by tribal and urban community members, leaders, healthcare providers, and others, as we all work together to, effectively address those cancer solutions. Oh, I think you're muted, Melanie.
Thanks, Melissa.
Yep.
Sorry about that. So this month, January, is Cervical Cancer Awareness Month, and I know that ACAF has been really busy in sending out messages and promoting screening during the month of January. Could you share with us a little bit about your campaigns, your efforts, your reach to educate American Indian women about cervical cancer in Minnesota? Especially Turquoise Thursday. Tell us more about that.
Yeah, so this year we changed Turquoise Thursday from Turquoise Thursday, which is, a change for us. But again, it's this national campaign that is dedicated to doing everything we can to eliminate cervical cancer within Indian country for female bodies. And hearing Tina and Mariah share, there's been so much great information that have been shared. And so really, what is ACAF's role in being that partner, trying to come from that cultural lens and being able to know that we do, again, just recapping that American Indian, Alaska Native women have that higher occurrence of cervical cancer compared to white women, and are often diagnosed at later stages when it's harder to treat. So, how do we bring awareness on the importance of preventative cancer screenings? How do we educate and provide education that, is sound and makes sense to our communities? And so this month we've been conducting social media campaigns on Turquoise Thursday to really just highlight, what information is out there. We encourage folks to wear turquoise. We encourage conversations in community, and just again to normalize the conversation of preventative cancer screenings. And, we have 2 new resources this year to celebrate Cervical Cancer Awareness Month. And, really honoring, what does it mean to be culturally tailored, to be able to see a resource that my daughter can look at, and to see that those are, people that look like her. Growing up, I realized, going to the Indian Health Service, like, there was nothing that represented who I was in some of the resources and educational materials. So how can we help our communities resonate and understand the materials that are being shared with them, and to be able to have a comfortable conversation with their provider, because we know that, cervical cancer does disproportionately affect our Native communities. And, those numbers are much higher with that occurrence. And so just, again, hoping that, we share through social media, we work with partners, both in Minnesota on a national scale with tribal clinics, urban clinics, to host events. It's been a little different in the pandemic, but how can we really encourage clinics to find ways to promote the importance of preventative cancer screenings?
Thanks, Melissa. One of the things that we've done this year is that we've been working really in close collaboration, SAGE and ACAF and our partners, as well as the American Cancer Society and Breast Cancer Education Awareness, to try to collaborate and promote each other's events, and just support all of the work that's going on, because we all have the same intention in mind, to get women screened and to get them into their preventative care. I can't tell you how helpful that ACAF has been to the Department of Health in helping us to understand that culturally, sensitive approach, and how important it is to work in our community. So thank you for that partnership. So we've talked a little bit about barriers, or others have talked a little bit about barriers to screening. From your perspective at ACAF, what are some of those barriers that you see for people coming in to get screened?
Yeah. So again, just highlighting the importance of those transportation difficulties, not only for our rural communities, but for our urban communities as well. And, hearing what Mariah said, I think needs to be repeated on the importance of the support that some of these programs offer to remove and reduce those barriers. Lack of childcare. I can admit I probably didn't go in for a cervical screening when my kids were 4, 5, and 6. Trying to navigate that and work, and, how do you prioritize your health? So how do we really help our communities, who have, families, intergenerational families under one household, really be able to balance the lack of childcare? Another thing we think about is those negative perceptions of healthcare providers. How do we, address the mistrust that does exist in our healthcare systems for our Native women? We have wonderful, I think there's wonderful staff at NAC and the Indian Health Board. And so when we think about our Native patients that can't go to these clinics or don't have close access, and, they go to these larger health systems, what are those misperceptions that, the staff have about Native women coming in? And so how can we help build trust with the healthcare system when they're working with our patients, with our relatives? And how can we also, again, culturally tailor resources and help our Native women be advocates of their body? And that part of that is scheduling those preventative cancer screenings. I think that can go into that poor patient-provider communication, being able to be comfortable to advocate for your health and everything about your body. Your body best. So kind of going in with that framework takes time, right? To be able to trust somebody that, being safe with your body takes time. I also think about, those long wait for appointments, or, do I have to call this number? And then how many times am I going to get transferred? Like, that's a barrier. Again, somebody like me, or, even scheduling other appointments. One thing I wanted to mention is, what is the patient's past medical history? What is their, for both men and women, what is their past trauma? We look at those rates for American Indian, Alaska Native women in sexual and violent abuse. And, do our providers take that into consideration when you're about to go in for a screening? And that could be very intimate, especially if they're in that room alone with the provider. So a lot of barriers. I'll stop there as I feel like we could keep going.
Thank you so much. I think, half of the battle is understanding what our relatives, as you say, are facing in those clinics, and to get the care it is that they need. So I appreciate hearing from you and others, their understanding of what those barriers are, or just recognizing that they exist, and specifically for Native people and the healthcare system. So recently, Sage did an interview with a woman from the White Earth Tribal Reservation, and her name was Danielle. And Danielle shared her story about her cervical cancer diagnosis and her gratitude in working with Sage at that time. Her story ran in the Circle this month. She'd shared that she had put off getting her Pap test for 20 years. And I've realized that there are lots of reasons why people don't receive regular cancer screenings, as you all have talked about. But I'm wondering if you could tell us if in your work you see urban-rural differences and barriers to get screened and get their preventative care.
Yes and no. I think, again, we look at being in an urban area and you think there's more options, right? There's more healthcare, but it's like being able to understand how many hoops do you have to go through, or we think that because it is the Indian Health Service that you should be allowed this screening, which, we do want our relatives to advocate for those screenings. But again, if this clinic doesn't offer it, are they referring the patient out? Do they have to go far? Definitely look at, our urban clinics and our rural, oftentimes are underfunded through the Indian Health Service. And so how do we, ensure that both needs are met in the urban and in the rural communities? And, reading Danielle's story, it's that, she said, I think she waited many years to go back in for that screening, and understanding that, and, that fear and that mistrust, and, where are those reminders? Where are those conversations if they're not happening in the clinic? Like, how can we work with, community partners, tribal leaders, stakeholders to really bring about conversations, again, that normalize cancer screenings? And we know that oftentimes there's some Native communities that have a taboo that if you talk about it, then it'll happen. So how do we, really normalize conversations about cancer screenings? Because we know that cancer screening saves lives, and we want to ensure that our relatives have access to these screenings because they do save lives. And the earlier the diagnosis, as Tina and Mariah mentioned, like, there's more options for treatment. There's a higher survival rate, and those just, often are not happening in our communities right now. Hopefully I answered enough.
Thanks, Melissa. Some really important points. I think that in the comments section, they did include the link to the article about Danielle. But I know that ACAF has also been collecting and sharing stories about women's experience. Can you just say a couple words about that?
Yeah. So, being able to, connect with survivors and find the importance of them sharing their story and being okay with sharing their journey in such a sensitive topic. And, we are thankful for not only our cervical cancer survivors, but other cancer survivors that have, shared their story and advocate for it. A couple of our ACAF board members are survivors themselves. And, some of the work we've been doing with the COVID pandemic is to really come from that lens of be a good relative. And so just honoring those stories, because they are being good relatives, and sharing those stories on a national scale. And, we also have a cancer survivor support circle that happens twice a month that, is available on information is available on our ACAP website and our social media, but being able to come into a sacred and safe space to share, to just be a listener, is also available for our survivors.
Thanks, Melissa. I think that at this time, we're going to bring all of the panelists back. And I think Robert is also going to be back. Is that right? Robert, are you joining us?
Sure.
And,
Well,
I think we're going to be available to answer questions or any further comments that people have.
I think it's really, really important what everybody's talking about. And I know one of the things, we're probably about 10 minutes away from ending the radio portion of this, but we can go as long as you want after that 10 minutes. But I'm going to jump in and give a station break in 10 minutes. But great discussion. The disparities and all those things that you young ladies are talking about is just imperative.
So I did want to read the last comment here from Dr. Anthony Stately, who says that my mother passed away from cervical cancer when I was 25, after years of not being diagnosed properly and finding her tumor much too late. In the 80s, we had so many barriers in place for her to get the care that she needed. We're much better off now, but we still have work to do. And Dr. Stately goes on to say that I'm really proud of the partnerships that NAC and ACAP have formed to tackle this problem and others in our community. Okama is asking, does SAGE work with IHS programs? Some people only have access to IHS clinics. Tina, do you want to take that one?
We definitely work with IHS clinics. Yes, absolutely. We have relationships with them. And so if you were to call our call center, you could get connected with an IHS clinic and go directly to one of them. And we work with the IHS clinic to still cover the breast and cervical cancer screenings. So we appreciate that relationship that we've built over the years. I think we've had those relationships nearly since the beginning, since this started. So it's been very beneficial for us to develop those.
Other questions that people have or other comments, Tina, Melissa, Mariah, that you wanted to make? Mom's the word, huh?
I think it's important to highlight seeing the Minnesota Department of Health highlight the importance of this community, right? We see the disparities, we know what they are. And so being able to not only look at the Minnesota Department of Health's cancer plan, but also to dedicate, funds and dollars to our tribal communities to address the cervical cancer disparities within Minnesota.
Anything in closing, Tina or Mariah?
I'd just like to say that I greatly appreciate the partnerships that we've built. And I'd like to thank, both Mariah and Melissa and Melanie. You've done a great job of asking us questions to really help people what they need to hear out there, help them hear what they need to hear in order to make good decisions and to understand that we're here to help all of you. We all work together really closely, have relationships built. We talk with one another on pretty much a weekly basis. And so you could reach out to any of us and one of us could connect you with the other if needed. So I hope that we have shared with you information that you can use to your advantage to help either you or your loved ones get the care they need.
I think it would be great if we could talk about how we can get in touch with you. Maybe just a shout out to a website again or a phone number. That would be great.
I know Tina has this memorized. Why don't you go ahead, Tina? Maybe we can share it in the chat too.
That sounds good. You can reach us on our website, which is www.mnsage.com, or you can reach us through our call center, which is really a nice way to connect with us. The women are very diverse there. They have a lot of experience in helping people understand cancer. And that phone number is 1-888-643-2584. And another way of thinking about that is 1-888-6-HEALTH, HEALTH.
Melissa, would you want to share your contact information? How did they reach ACAF?
Yeah, you can go to www.americanindiancancer.org. You can also search American Indian Cancer Foundation on Facebook, Instagram, YouTube, LinkedIn, Twitter. So AmericanIndianCancer.org.
Mariah?
Sure. So our general clinic line is 612-872-8086. And you can check us out at our website, our Facebook page. We have a really comprehensive list of services that we provide, including our preventative and community health services and mention of the SAGE program as well.
Thank you. And then there are a couple more questions on the chat. The last question that was asked is, when you say disparities, do you mean disproportionate to Native women versus the general population? Who would like to take that? Melissa?
I can try to best answer it. So yes, when we say disparities, we know that cervical cancer disproportionately affects Native communities. In various parts of the region across the United States, our Native relatives have a much higher occurrence of cervical cancer than non-Hispanic white population. Just to give you a couple numbers, when cervical cancer is detected at an early stage, the 5-year survival rate for people with invasive cancer is 92%, whereas if the cervical cancer has spread, the 5-year survival rate is 58%. And so we kind of were talking throughout this conversation, I think Tina and Mariah and I all hit on it, that American Indian Alaska Native women are often getting screened for cervical cancer at later stages when it's, harder to treat. So I'll also invite Mariah and Tina to share.
Anything else that you want to add, Mariah or Tina?
No, Melissa did a great job of explaining it.
So there's one last question that I don't think that we've asked. Isn't it true that the Minnesota legislature has made it possible for all women who are diagnosed with breast or cervical cancer to get the care they need, regardless of their financial situation and ability to pay? And I believe that several of you had mentioned MABC. Tina, do you want to respond to that question?
Yes, that's a little tricky, and it's nearly accurate the way that it was stated. Medical assistance for breast and cervical cancer does cover treatment for anyone, and some types of diagnostic services as well, for anyone who has been screened through the SAGE screening program or the Screen Your Circle program through the American Indian Cancer Foundation. That said, if the individuals come in and they're underinsured, they may not be eligible later for MABC if they have, for example, coverage through their insurance that will cover the treatment side of it. And then that also doesn't come into play for the undocumented folks. And those individuals, then we usually get them on, it's called emergency medical assistance for a period of time to help them with their treatment costs.
Hey, I just want to jump in here. It's been an hour. I just want to say, hey, we'll be keeping on going with this discussion, but we're now done on the radio. And I want to just say, Native Roots Radio has been really proud to host this show, along with Minnesota SAGE Cancer Screening Program and reducing the impact of cervical cancer in Native women. Thank you so much, everyone, and back to the show.
I just wanted to take the opportunity to thank Robert and Ogama, all of the tech people that came on to kind of help us through this process. It's been really interesting and fun, and we just appreciate the opportunity to share these messages. I also just wanted to thank the panel members. Thanks so much for taking the time to come out and share your experience and your knowledge. I think it was just a great service for our Native community. Thank you. Other questions, other comments? Okay, I think we're done. Robert, are you going to take us away?
Well, I just want to thank everybody again. This has been a great broadcast, and it'll be again seen and listened to. You can catch it anywhere, but it'll be listened to on AM 950 on Saturdays. This Saturday at this Sunday at 6 p.m. So I wanted to say Hainapi and good night, Haijuoni, to all our friends and relatives.
Thank you.